The broadcast is now starting. All attendees are in listen-only mode.
Well, hello everyone, and welcome to our webinar. And it is the top of the hour, so let's go ahead and get started. I am Emily Eberly, and I'll be your behind-the-scenes producer today, and I want to thank you so much for joining so that we can focus together on the risk and prevention of catheter-related bloodstream infections. And now I would like to introduce you to Susan Markovich. She's the Clinical and Training Specialist for Teleflex Medical, and she'll be your moderator today. Susan?
Thank you, Emily. Good afternoon, everyone. As Emily said, my name is Susan, and to give you a little bit of background about myself, I am a registered and certified nephrology nurse. I have been a nurse for over 30 years, and the first 10 years of my career was spent in critical care. Since then, I have focused my career on nephrology nursing and have held various capacities in the dialysis industry in clinical training, operational management, and also in clinical capacities. I'd like to welcome all of you to our program, and our discussion is titled Risk and Prevention of Catheter-related Bloodstream Infections Associated with Hemodialysis Catheters. Our speaker today is Dr. Faisal Masud. Dr. Masud is an associate professor of the Department of Anesthesiology, Weill Cornell Medical College at the Methodist Hospital in Houston, Texas. He's also the associate professor of the Department of Acute and Continuing Care at the University of Texas Health Science Center at Houston. Dr. Masud is the recipient of several honors and awards for his work in infection teaching and mentoring, and carries on an active teaching and research schedule. A highly sought-after speaker, Dr. Masud has spoken at numerous domestic and international conferences on strategies to reduce hospital-acquired infections. This event is sponsored by Teleflex Medical. Dr. Masud is a consultant for Teleflex Medical. Views and opinions expressed are those of Dr. Masud and do not necessarily represent the opinions and policies of Methodist Hospital and/or Methodist DeBakey Heart and Vascular Center. Dr. Masud did not disclose any conflicts of interest in the development of this presentation. At the end of this webinar, you can obtain 1.0 contact hours by going to www.sextesting.com/VH. Complete the post-test and evaluation form, and upon successful submission, you'll be able to print out your certificate of completion. Our provider, Sachs Communications, is approved by the California Board of Registered Nursing, provider number 14477. No off-label use will be discussed in this presentation. So with that, I'd like to go ahead and turn this over to Dr. Masud. Dr. Masud?
Good afternoon, Susan, and thank you for that introduction. Good afternoon to all of you. It's my pleasure and honor to talk to you today. My hope is to kind of go over the whole spectrum of catheter-related bloodstream infections and acute hemodialysis catheter. And hopefully by the end of this discussion, you'll be able to take some key points and some key messages and action items which you can apply to your institution, because I view you all as the front point leaders who will champion the cause at your institution. With that said, so let's get this started. The learning objectives are: list the risk of bloodstream infection associated with acute hemodialysis catheter, describe evidence-based strategies to reduce bloodstream infection associated with catheter. Because at the end of the day, utilizing the knowledge and having come up with some action items, that's a very critical point. Right? Okay, so the background, and again, a lot of you may know this information, but it's very important to bring everybody on the same page, and it's very important to kind of build up the whole scheme of things. With that said, acute kidney injury, as you know, is sudden, temporary, and sometimes fatal loss of kidney function. The complication related to that is fluid imbalance, high potassium level, acidosis, and damage to other organs. And some of the therapies which are listed are supportive care, continuous renal replacement therapy, and dialysis. Patients with acute kidney injury need acute dialysis catheter, especially when they develop that, because that's the first line of treatment, again, to treat some of the fluid overload issue, the acidosis issue, and electrolyte issue. However, these catheters per se are not used only in patients with acute kidney injury. They actually are used in other clinical scenarios in different patient population. And these patient populations are sometimes these catheters are used for in trauma situation when you have to give massive amount of fluid, because these are big size catheter. As you all know, that the size of the catheter lumen may have an exponential impact on your amount of fluid that you can give. Also, similarly in septic shock patients with hemodialysis, as we mentioned, patients requiring continuous renal replacement therapies similar to dialysis, and that is actually much more in ICU setting, because this is where it can be done. And apheresis in extracorporeal therapy, and like if you have patients who are transplant patients, sometimes you have to do plasmapheresis and everything. And even though that's short term, but the impact and significance is the same. So these catheters, even though they may be labeled as an acute hemodialysis catheter, but as you can see clinically, their use is a lot more. And that's why it's very important to be aware of that and to recognize that. These catheters, can be most common site, as you know, these catheters are placed in the internal jugular vein or the femoral vein. Unless it's very rare circumstances, you end up putting an external jugular, in which the external jugular is huge, but typically in another place, and occasionally in subclavian veins. But the most common site are internal jugular vein and femoral vein. Now, I always like to remind people, basically, we've been talking for quite a few years about central lines, and actually these are central lines and steroids. They are in big vessels, they are big size, and they are near the, especially if you're putting through subclavian IJ or EJ, they're near the heart. So these are central lines. So it's very important to afford the same respect, the same care and maintenance, same vigilance, and same due diligence, which we have been focusing a lot more. All right. Again, it just goes to show not only that these catheters have to pay respect, but they actually may pose the patient to a high risk of infection. As this study from Dr. Mackey showed, that they are the highest risk. The patient much more risk, prone if they have these catheters. 8% or 4% per 1,000 days. Lo and behold, why did we not do a lot of that stuff, 6-7 years ago? And especially since 2008, when Medicare said, well, we're not going to be paying for central line and all the stuff. So it's very important to recognize that. Incidence of infection with central lines is very important, and the reason I'm saying these are central lines on steroids is because they are, in fact, big central lines. In 2009, about 18,000 bloodstream infections occurred in ICU patients with central lines. About 23,000 more patients were treated in other areas, also developed similar infection. But the third bullet, which is all this data from CDC, show that about 37,000 bloodstream infection occurred in 2008 in hemodialysis patients with central line. That's a big number. It just goes to show there's a lot of more work to be done, and it still needs to be done. CDC data updated from in 2010, some of the data kind of reminded people was 380,000 plus US patients relied on hemodialysis. 8 in 10 of those patients started treatment with central catheter. As you already know, this is how you start. We don't put fistulas on day one, and we don't put tunnel catheters for long-term in day one. So they kind of pretty much start in this scenario. A hemodialysis patient is 100 times more likely to get a bloodstream infection from MRSA than other people. I was surprised at that. I didn't expect. I thought they were high, but this is quite a bit high. So this goes to show, to remind people like me and others, is we have to pay a lot more attention because they are much more vulnerable. Not only that, the rate of hospitalization in hemodialysis patient due to bloodstream infection has actually increased by 51%. So not only that these patients, as you remember in 2008, they had 37,000 bloodstream infections. These patients have much more likelihood for MRSA, almost 38,000 and counting. These patients rely on dialysis catheter alone. And again, this is only 380,000 dialysis catheter. This does not include the patient who need for shock, trauma, apheresis, and everything, as I told you before. And you know, this National Healthcare Safety Network report, I'll go with you, but let me share you something which recently came on from CDC. As you know, that they are paying much more attention to patient central line infection in dialysis patient, and they've actually changed the metric. This came out actually 2 weeks ago almost, that they're going to change the methodology and some of the reporting mechanisms starting in 2014 for patients who have central lines in with dialysis, and they're changing verbiage. What it reminds really is that the CDC and NHSN are really paying a lot more attention to this because they recognize this is really the area of vulnerability. So let's go back to this slide, in the National Healthcare Safety Network report, which came out in April of this year. Why am I sharing this report with you? It's very important to recognize that a lot of work has been done to reduce infection in central lines, in acute care dialysis, catheter, and everything, but there's a lot more still needs to be done. So let me show you the slide. Next one. All right. This is from NHSN data, which shows that in an ICU environment alone, in critical care, and you have your one patient number of CLABSI, and the pool mean was 3.7. In major medical teaching, the pool mean was 1.2, medical all other 1.1. And if you look at the spectrum in all across, this graph, this table is in front of you, the range goes from 0 to 8.4, 0 to 2.9. So that means there are some institutions which really have set the good bar for everybody else, but there's a lot of institutions which have to step up also. The next slide shows that these patients, which are a little bit more focused, even though their number location is less compared to the previous slide that showed you, and number of CLABSI is less because there are less number of patients, but these are the hematopoietic stem cell transplant, the general hematology oncology. These are more vulnerable than the other of the patient population, and their rate, you know, is higher. So not only that we have to worry about our general ICU and other, but in a subcategory of these hematopoietic stem cell transplant and other, they're much more risks. So what I'm trying to kind of remind the focus is there's a lot of good work which is done to reduce central infection. You know, the Peter Pronovost work in Michigan and Keystone, but there's a lot of work still needs to be done. How the impact of vascular catheter-related bloodstream infection. And I asked this, and I've been, you know, I've been quite a bit, worked with quite a few chapters of APEC, Association of Professionals in Infection Control and Epidemiology, and I asked this question whether it is my institution, other institution. I'll encourage you to ask this question with yourself and what actually it is the rate of your institution, especially dialysis patient. And it's very important for the key stakeholder people to know this information. Not only what is the rate, but do you know how much is impacting and costing your institution? And I found that information to be very relevant because when I'm asking for more resources from my institution, we encourage people to engage their hospital administration, to engage other people, whether it's physician, nurses. Sometimes the dollar number along with the rate makes an impact. So it's very important, and that's not one of the most easy number to get, but I would encourage you to do that because once you show that it's got a huge impact on the bottom line of the institution, people sometimes pay more attention. And if you get to know the rate, is that an acceptable rate? You know, everybody I've talked to in the last few years, everybody told me, well, the only acceptable rate that we want is 0. But, you know, as you know, the 37,000 alone took place in 2008. So what we wish and what we have to do to get to our wish and our goal It's still in the making. And again, as I mentioned, what is your goal? And most of the time, the response, I always actually have gotten a response of 0. I've yet to have meet anybody who said me, well, my goal is 5%. And that's the good news. That's not what we're aiming for. The question I pose to people is, actually, have you done everything you can in your facility to achieve your target? Because if you look at the guidelines, if you look at the recommended best practices, quite a few times institutions pick up 1, 2, 3. But when you're trying to be excellence, when you're aiming for excellence, when you're aiming for 0, and we're trying to maintain 0, you really have to do pretty much all the 10, 11, 12 steps, whatever the number is, do all of them. And you have to try to do them consistently, because that is where the challenge comes into place. The hard part is, how can you sustain your effort? I mean, the patient that we all are seeing are a lot more complex. The patients are living a lot more longer. They're showing up for many different hospitals. So it is a challenge. And mind you, these patients which we are our dialysis patient and our renal failure patient end up, are a high risk for concern with readmission. And if they get readmission, especially if they're infected or anything like that, that is also a negative impact, because Medicare and other institutions publicly have you reported for readmission rate, and they don't even reimburse you for some of those things. So mind you. So when you want to say, well, this is not good, we want to do something different, we would like to change things around, these are some of the barriers which people typically encounter. And this is not limited to only centerline, but can be applied to any approach that you're trying to launch. First of all is, well, we don't have any problem. We don't have any infection. And more often than not, that's not the most accurate information. People have selective, so you want to really know true infection. So the first thing people do is, bad things don't happen here. The second is poor human system interface. People don't know where the supplies are. They may have supplies, but they may not be all in one place. They may be in different location. They may not have all the elements. So even if there is an intention to do good, whether you're inserting this catheter or you're managing the catheter, if the human interface and system is not good, then things get dropped off. Time shortages, that is the biggest challenge we all face, is we have got 10 things to do within 3 minutes. And so it's the issue is, how much can you do those things in a reliable, consistent manner? Other aspect is management unresponsive. For example, you want to get a new kit. You want to upgrade your system. You want to upgrade your kit. You want to upgrade your dressing. You want to do more surveillance. You want to do monitoring. You want to do more education. And yet you ask for your administration support and it's not there. Well, that is another thing which leads into not being excellent. Unfamiliarity. We have not used this thing. We have not used this toolkit. We have not used this catheter. We have not used this dressing. We don't know how this works. Again, another con. Misperception of risk. Well, most common thing, well, it's okay. Patient do fine. What's the problem? What's the big deal? And again, that leads to a sense of patient, people not doing what they should be doing. Inexperience, not lack of caring. And that is where part of the thing of mentorship, especially for the dialysis, nephrology nurses, the ICU nurses, the outpatient nurses, the mentorship of nurses, the mentorship of physicians who are putting hands on does play a role. So for any kind of medical related, how does the infection does take place? So if you see that you have an infectious agent, you have to go through it. It has to enter the body somewhere, because the best organ that we have is our skin. And once it enters the body, it starts multiplying. But not everybody gets an infection, because in quite a few patients, our body is able to ward off and kill the bugs. But then you have to have a susceptible host. And if it's a susceptible host, that's when you get infection with fever, white count, other systemic issue. So this is how the whole process takes place. So where does the role of intervention is? This is the role of prevention. You prevent the bug to take place. This is the stage of diagnosis, when they start showing some symptoms. And when you have to have diagnosis, that's when you start treatment. What we want to aim for is this area. Because if you prevent the bug to take place and you prevent all of those things to take place, then you prevent infection, you break the circle. This methodology of IHI of plan, do, study, act, it's been multiplied in multiple scenarios, multiple institutions. First of all, one should ask, what are we trying to accomplish? And you can say, well, we're trying to accomplish zero infection prevention in our patients, you know. How will you know that a system changes and improvement? You start planning new things, you do a protocol or a process improvement, and you study. And more often than not, you'll find out that what you wrote on a piece of paper is maybe quite a bit different what you may end up practicing after a few months. That's why you need to go with an open-ended mind to see this is how we're going to do it, and then you tweak it based on what your clinicians and how your scenario is. And then based on tweaking, you keep on studying, and typically if you look at most of the protocol, most of the things undergo around 10 revision by the time it is a great tool which people can use on a consistent basis. So this is a great tool. It works pretty good in many scenarios. The reason I want to share this slide with you, the role of leadership is very, very critical. You cannot, the staff cannot do it if you don't have committed leadership. That means if the hospital CEO is not committed, if the chief of nursing, chief of surgery, chief of nephrology, or chief of interventional radiology not committed, you can't do anything. And the reason it is important is that if the nephrology services say, well, we're going to do this thing, nobody's going to do everything different. But if they don't see the leaders do what is the best thing and the right thing, if the leaders don't set some goals, then anybody and everybody do whatever they feel like doing, or they think they're doing the right thing, but may not be everything. So you have to set standard. This is how we as an institution will practice. And when you have to kind of do this thing, that's when you start giving people a time and opportunity to develop those tools, to practice, and to make it happen. But the most important thing is I believe that it empowers organization, institutions, and people is sharing of data. When you have true, honest sharing of data, people do behave better. And for example, if you are an institution and if you got different ICUs, you can compare different ICUs, what is the rate of infection in their dialysis patient. If you got 3 or 4 dialysis centers and your patients coming back and forth, you can compare them. If you have different areas of floors which manage dialysis patient, you should compare them. So it's very important, and I have found out that competition drives a lot of good work because nobody wants to look bad. In order to be successful, you have to set some goal, and I'm repetition on some of the points that I'm saying. You have to set goal, and you're not going to go to zero on day number 1 or day number 2. You have to start setting. For example, if your rate is 1.5%, you say, okay, well, the first game we're going to reduce by 50%, and whatever you can choose, 1 year, 6 months, anything, and they start doing all of those things that we talked about, the plan, do, act cycle, and then see what works. And then you're going to move up on the next step. That means when you get successful the first time, you raise a bar higher. The next time you get successful, raise a bar more higher. And pretty soon, you'll be consistently. Just because a mandate comes in that we're going to have zero infection, it's not going to translate to zero infection day number 2, day number 3, day number 5. It doesn't happen like that. So how do these things get infected? As you can see, there are multiple areas of infection at the hub, at the site, at the skin, and there is bugs going from the outside to the skin trunk, from the inside, and inside is when you connect tubings or circuits or solutions which are not very clean, and there are areas that are contaminated. They can contaminate on the interluminally. Extraluminally, there's a tremendous role of skin maintenance, insertion piece, especially the hub piece wise. With all of this information, and quite a few people of you may already be aware of these guidelines, but I like to kind of reemphasize where some of the roles may make an impact. The first rule of everything, if you look at any set of guidelines, any set of intervention, really is to provide education and training to clinicians who insert and manage the line. If you recall, on the Keystone project, they all talk about a first step as far as dressing, gowning, and quite a few areas it has improvement. But we cannot minimize the role of managing people who manage these lines. So that's why it's very important. And not only that, if you look at the second bullet point, that you have to not only provide education training, but you have to periodically assess, do they remember what this said? Just because you showed a PowerPoint 1 year ago, please do not expect that people retain that much, because there's always some campaign. There's a DVT campaign, fall prevention, all of the other things. So people are basically overburdened, overwhelmed with a lot of this information. So if you don't repeat your message, if you don't remind people, then the likelihood is that they will say, yes, I did that course, but their practice would not change. Weigh the risk of where you're going to put the line in exactly, whether it's, as we talked about, IgA, subclavian, what is the risk? And again, this is coming from mainly for all center line, and that's what they mentioned. Avoid the subclavian site in hemodialysis patient and patient with advanced kidney disease to avoid risk of stenosis, because they're trying to preserve that arm for AV fistulas, and most of you may already know that. Other thing is very, very important is ultrasound guidance to place lines. Whether you're putting a femoral line in there, whether you're putting an IgA in there, it's very critical. Why? Because there have been numerous studies, numerous guidelines which show that ultrasound utilization for placing these lines minimizes the number of times you make a hole, minimize complications, and minimizes infection, minimize DVT. And I can tell you, I was reading an article from one of the anesthesiology journal yesterday, and there was a case report in which they put a big 9 French catheter. They were putting a line in the neck, and they put the 9 French catheter, lo and behold, in the spinal cord area. And one of the things they said at the end of the thing was that, well, we would recommend use of ultrasound. Just kind of remind, I've never had that. That's why it was a case report. But I just want to re-emphasize the ultrasound utilization is critical. Let me go to the next slide. Use maximal sterile barrier precaution, a cap, mask, sterile gown, sterile gloves, and sterile full body drape for insertion of these lines. And I'm going to go in the later on slides what exactly it is. Everybody says that, but quite a few times it's very critical to remember how we do that, and I'll elaborate on that. Prepare clean skin with 0.5% chlorhexidine, preparation with alcohol before CVC and catheter inserted and dressing changes. And if there's a contraindication to chlorhexidine, use tincture of iodine and iodophore, or 70% alcohol as alternative. It's very important to know that. Then the good thing is that the allergy to chlorhexidine, it's extremely rare. So we have this molecule which is making an impact. And again, if previous successful implementation of CLABSI has not worked, then use this chlorhexidine, sulfasalazine catheter, or a minocycline if they're going to be more than 5 days. But let me just again remember that this is if the other strategy is not working. However, in this day and age of zero tolerance, you may end up choosing all of these strategies much more sooner than later. We all know about checklists. I think that's been a great process improvement place, but you'll see that what has happened nowadays with the checklists is because there have been so many checklists that, there's a checklist. My daughter has a checklist for me. Really is the goal of checklists when it was envisioned and was implemented, and a lot of those things was that, it's a reminder that all the things been done. Now, what I'm hearing from a lot of people across the nation is people are actually doing the checklist in the computer, checking mark on it, but actually not being necessarily on the bedside. So it's not only about using the checklist, but actually how are you going to change the process? For example, if somebody is putting a acute care dialysis catheter and they contaminate or do not realize they've done it, and the nurse tries to stop them, if they don't know how to have that dialogue, then it can become a very match of egos and fights or challenges. So it's very important. For example, there's a very nice terminology which is used at the bottom of your screen that you can see. If there is something that is contaminated, one can say that the sterile field has been contaminated, rather you contaminate the catheter. Well, if there is an inappropriate communication, it doesn't work out, and the whole team model collapses. And if the patient is awake, they may not be thrilled that people are fighting you putting catheter in them. So it's not only about the checklist, but the person who's going to do the checklist. And it's very important that person is a neutral observer. Hand hygiene, it's something which has been there for beginning of, so much. The issue really is that surgeons and everything has had a very good bar of hand hygiene, and other people have not. So it's very critical to remember hand hygiene. And again, if you look at the national data, for healthcare provider, the average compliance in hand hygiene is around 60%. I think there's a tremendous opportunity with that. And the more you do it, the more you focus on it. And again, it's part of the whole campaign, and it does pay off in multiple issue-wise. Prepping, cleaning, and again, if you have to clean the area with 2% chlorhexidine play solution, and the important thing is once you clean it, you have to let it dry. It does not work if you don't let it dry, and you have to let it dry for 30 seconds. And I don't want to count 30 seconds in this presentation, but I would encourage you to count 30 seconds, and you'll recognize that it actually feels like a long time. So even though it says 30 seconds, but you have to kind of make people take deep breaths and make it wait 30 seconds. Otherwise, it does not work. Maximum cerebral precaution when you talk about it. So, let me show you this picture. And in theory, if this person is compliant, they have a cap, mask, gown, glove. So, but if they don't do it properly, it doesn't work. And there, as you can see, there are multiple areas of vulnerability which are going up. So I'm just kind of highlighting that with the red arrow. So in theory, they have cap, mask, and glove, but if somebody doesn't help them, and again, remember the surgeons in the operating room, somebody's helping them to cap, mask, gown, and glove. And similarly, if somebody's putting the line in, somebody else has to help them, whether in the IR suite or ICU suite or ER suite or other places wise. And the next picture is a little bit better at how this should be. So it's very important, just because you have it, it should work properly. Now this is about, cover the patient head to toe, and there are certain, kits or dressings, and people have sometimes those bags which have these kits, and which is not a full body drip. It's very critical to do the full body drip. Use an all-inclusive catheter cart or kit. A catheter cart or kit that contains all the necessary components for aseptic catheter insertion. It should be available in wherever they're inserted. Why? Because every time you walk away from the patient bedside to get another kit, to get another component, you are potentially and exponentially increasing the risk of infection. And the classic example I'll give you, when the surgeons are operating in the operating room, and the nurse is giving them procedure, they don't step out for every single thing out of the room. They have a whole thing over there. So it's very important to use a catheter or a kit which has everything in it. And this is an example of a kit which is pretty much everything that you can think of, from mask, cap, prep, all the elements that you can think of. It's a very good example of a kit which you can use. You open it up and you're there, or your stop sign piece is there, which can allow people to stop, put it outside the room. It works. You have the checklist piece. So I think this is a great example of a kit which allows all the elements. People don't have to walk off to do this thing, and it's pretty comprehensive with a full body drip. So it's a great setup. So this is a good example of that. And again, this kind of kit has all the elements that you can think of, from different latex-free components, the checklist, the stop sign, the alcohol gel, the sharp HE. So the reason I'm showing you this example is because you have to envision things to minimize human system error failure issue. And remember, I showed you previously the poor human system interface leads to problems. So you want to minimize that. So not only that you should have a kit like that, but you should have a cart which had multiple kits, because things can get contaminated. It does happen. So you don't want to walk away and figure out where other kits are. So you should bring the cart to the patient. The kit should have everything, and the cart should have multiple of these kits. And then we talk about the catheter impact. We talked about the antiseptic or antimicrobial catheter. Again, they talk about if you're on the pre-cell line for 5 days, mainly for central line issue, that if the routine processes don't work. But in this day and age, when you're not going to get paid your institution, you're going to be publicly reported. So the race is really to minimum tolerance. So it's very important to have those patients use all elements of guidelines, all pieces, because remember the data that I showed you, despite all the effort, 37,000 bloodstream infection took place. The patient, the risk of hospitalization of renal failure patient has actually gone up 50%. They're much more vulnerable patient population. They get access a lot more, and they're already compromised patients. So, my take on this thing is these are vulnerable of the vulnerable, and a lot of things to be done, and everything to be done to minimize risk. So that's just, I would suggest, and that would be. CDC's most commonly reported causes of pathogen coagulous staph, Enterococcus, Candida, gram-negative, and these agents at this website are much more. So it's very important to use kits which have coating in them, especially the chlorhexidine sulfasidine, which does make an impact on preventing the bugs to migrate from the catheter and cause harm. They have this example of the ARROWg+ard Blue Plus, which is a chlorhexidine coating. They've got multiple data with it. It reduces bacterial colonization, it reduces bacteremia, and more than the data they have it on that side. So why am I talking about technology solution in everything that we do? Is, when you do certain basic step, you reduce certain percentage of risk in catheter, as you can see from this first part. Then you do at a high level more steps. And then you apply technology and solution, that's where you get the most bang for buck. So, there is certain impact. You're able to reduce your infection to a certain degree over there. You do more steps, and when you add more technological solution, you have an exponential. As you can see, this is the rate of infection goes down. This was published in JAMA, and just going to show why that. So why is that? Okay, so you have hazards or things or bugs which are trying to cause infection. You can have an impact of barrier precaution, catheter size and tip, aseptic management, and SS and dressing. But you still can have an infection can take place. So we still have to look at what else can we do. As you can see, these are the steps: maximum sterile barrier precaution, correct catheter size, aseptic care, SS and dress. So that's where the role of technology does make an impact. Boom. So even if you do all the steps, this has a role. And this does make a difference, because the coating, the chlorhexidine coating, can minimize the bacterial colonization and prevent that. So that's why if you're really trying to really start, you have to use every element, because in a vulnerable patient population, you have to think of all of this factor. Really, this is our goal. Our patients are surrounded with bugs. We want to create a safety zone from them. So whether they're from the environment, from tubing, from skin, from hand, we have to do, and that's what we all do, is whether a cap, mask, and glove, dressing, and all the stuff, is to create an environment which protects our patients. Disinfect catheter hubs, needleless connector. And again, the recommendation before accessing catheter hubs and injection site, your recommendation is to clean them for 15 seconds at least. Now, it seems very mundane. It seems so odd. But let me count 15 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. How many times have you seen these people doing on a consistent basis? I'm going to leave it open a question, and then you can answer yourself. The second piece is you have to think of dressing. Dressings and the cleaning piece go hand in hand, because that's where the care and maintenance piece plays. The cleaning piece, whether you clean it with alcohol or chlorhexidine, the dressing piece with this, with chlorhexidine impregnated dressing, whether they are different companies have different components out there, it does make a difference, because the integrity of the dressing and the people ability to access those hubs are what makes the patient catheter much more vulnerable. If you look at the whole spectrum, there is something to this chlorhexidine molecule. The chlorhexidine, skin prep, the chlorhexidine catheter, the chlorhexidine swabs, the chlorhexidine dressing. So I think this molecule is helping us in multiple areas. I think this molecule, while the bugs cannot fire resistant to it, has an important role and will keep on paying off dividends. So I would really think, and I want you to think about it, see how this molecule is making an impact all through the whole spectrum of these catheter, acute care dialysis catheter. Again, compliance, again, whenever you do certain things, you have to kind of look at people actually are doing it or not. People are compliant or not. People are much, because if you don't, and then as I showed you the previous slide of cap, mask, gown, and glove, well, people are, in theory, that person is compliant, but in practice, it didn't do anything with the patient. Patients still suffer because it was not done properly. So just because you launched a campaign, if you don't measure, if you don't audit, please don't assume that it is being done properly. Well, the good news, and I want to say that for good news, a recent study showed that following CDC recommendation, the vascular associated bloodstream infection in hemodialysis patients were reduced by 54%. And again, these were in an outpatient setting alone. And there are a lot more opportunity in inpatient also. That represented $23,000 in cost saving per patient. Data has shown that 58% fewer bloodstream infection occurred in hospital ICU patients with central line in 2009 than 2001. So whatever we're doing is making an impact. Overall, the decrease in infection saved up to 27,000 lives and associated with almost $2 billion saving. In 2009 alone, reducing infection saved about 3,000 to 6,000 lives and $414 million. So what you're going to do and hopefully champion at your hospital, at your clinics, at your outpatient, your inpatient, your ICU, makes a difference. That is very important. So these don't go in vain. Patient lives do get saved, and you save a lot of money also. So it's nothing but a good deal. So in summarizing all of this thing, I really would like to kind of take a 1 to 2 minutes. Prevention is a goal. It's very important for people to recognize the most bang for your buck is prevention goal. And why is that important? Because when you launch this campaign or restart your campaign or you expand this thing wise, you have to engage your leadership, medical leadership, administrative leadership, nursing leadership, nephrology leadership. Why? Because you can make the case in the data that I showed you, not only did they save lives, they save money. So it's very important. Otherwise, they'll end up being publicly reported and not getting paid. Right care right now for the right patient, that's from Society of Care Medicine. And my spin on this is, right line for the right patient for the right duration. It does make a difference. Save life, save money. You can't get a better deal than this. It means you have to make a business case for a hospital administrator to do those things, because you can't just do it if you have no manpower, you don't have proper kits, you have no resources. You really can't go to zero. You really cannot sustain to zero. You cannot be excellent. So it's something which you need to be empowered on. Make a patient care issue for physicians, people who are putting line into. This is benefiting your patient. It's not one versus the other. You can do the same thing, patient care issue for nurses. And I know the nurses are very, very passionate. They are known as patient advocates for a reason. They're very passionate about their patients. So make a case, can do this, cleaning those hubs, maintaining the dressing, this physician to use the right catheter, the right kit, it all pays off. It's actually all about quality care for both. Now the last piece I want to kind of mind is, what I've seen is there's a lot of enthusiasm. We start a campaign, you do a lot of work, and then in 2014, things fizzle out because people don't pay attention or they've got some more campaign. So remember, persevere, change is hard, and keep at it. With that, I'd like to pause for a second and give my mic to Susan for her to take the next step.
Thank you, Dr. Masud, for such a informative and relevant conversation today. Really appreciate all the information. We do have several questions that we will be taking shortly, but I just wanted to remind you of the CE requirements so that all of you can get your continuing education hours that I know you are all eagerly wanting to obtain. So remember, at the end of the webinar, you can get your contact hour by going to www.saxtesting.com/VH. Complete the post-test and the evaluation form. Once you submit that form, We will be sending you a certificate of completion for your records so that you can have that to maintain your certifications or licensure, whatever it is that you are needing them for. So let's go ahead and start with our first question. Dr. Masud, at the beginning of your presentation, you mentioned that in 2009 there were 18,000 bloodstream infections in ICUs and an additional 23,000 infections elsewhere in the hospital. You also commented that there were 37,000 infections in the dialysis population. Was that 37,000 in addition to the initial numbers that you quoted within the hospital?
Yes, there were addition to these 18,000 was specifically related to central line only, and the 23,000 more patients were in the ICU, and the thought was they were being driven by the central lines which patients go to the floor and the PICC lines also. So it's a combination of PICC line, central line, and what they did do is they kind of streamlined some of the this data, and they found out that lo and behold, we did a lot of work on the central lines, but the stepchild was this dialysis catheters, and they figured out that this 37,000 came from dialysis catheters. So yes, they are different.
Another question that our audience has is, you mentioned that you should not use antibiotic ointments or creams on catheters except in the dialysis population. Can you elaborate why the dialysis population is separated in that comment?
Well, for multiple reasons, more often than not, these dialysis catheters are placed in the femoral lines. And these ointments, previously, if you look at those ointments, when they did the studies, those ointments were placed a lot more in the skin area, and they were put a lot more in the IG and subclavian area wise. So in dialysis patient population, they figured out that in those patients, because a lot more of them put in the femoral area, the kind of bug that they encounter, those ointments do make a difference and are potentially better. So they were giving more choices to the dialysis patient. That's where it came from.
Okay. Our next question is regarding the use of prophylactic antibiotics after the insertion of a central line. The audience member is saying that they realize there's no data to support it, but many hospital policies require that prophylactic antibiotics be given after insertion. Can you comment on that?
Actually, if it means that after a routine insertion that they should get antibiotics, there is absolutely no data. Absolutely no data to do that. Now, what may be a little bit confusing is that if they're doing a surgical procedure, for example, which is a tunnel catheter, and sometimes the part of the surgical procedure, the surgeon may choose to give antibiotics, that's a totally different category. But for acute care dialysis catheter, there is really no reason. I have never given in the last, 18, 20 years I've been in practice, because, you're actually causing more potential harm of bug resistance and cost to the patient without any shown benefit. So I would recommend that they should, what I would recommend to do is for them to engage their ID physician and their infection control department, and all of these three people can help change some of those policies at the hospital.
Okay, thank you. Our next question surrounds the side-by-side studies of any antimicrobial impregnated catheters versus non-impregnated catheters. Are you aware of any studies that are out there that comment the effectiveness of the impregnated catheters versus the non-impregnated catheters?
Absolutely. There are numerous studies and which have shown that the impregnated catheter are far superior than non-impregnated catheter. And these studies were done even in patients in which they did all the bundles. For example, they did the whole cap, mask, gown, glove, and prep and draping, and they did with patients with non-coated catheter, and then they had coated catheter, and they did the whole cap, mask, gown, glove. And when they measured risk of infection, they found that the risk was 75% reduce of infection and CLABSIs and positive cultures, where as long with the coated catheter compare both the two category patients. So even if you have cap, mask, on glove, addition of impregnated catheter provided the extra boot and did reduce almost 75% the risk of infection. So there are numerous studies out there.
Thank you. Do you know of there being any evidence that antimicrobial alcohol or alcohol locks used to dwell catheters has increased the prevention of dialysis-related catheter bloodstream infections?
These caps or locks, there are at least 20 companies which have different. They are catheter with the negative displacement. They are with caps and locks with antimicrobial solution, with heparin solution, with saline, with other chlorhexidine. And if you look at different manufacturers, they all have some data to show that it does make an impact. And I would encourage the institution to look at, compare to site what makes a difference, because there's so many out there. However, what I like to remind is what you cannot replace is whenever the sports are accessed, there should be at least 15 seconds of cleaning. So yes, I mean, I can't right off of the head tell you exact study which looks at that category, but there are at least quite a few catheter hubs and connectors which are out there.
Okay, thank you. Our next question is asking about if there have been any increases in sulfa allergies when using any of the silver sulfadiazine impregnated catheters, and how much of a concern should a sulfa allergy be if you have a patient with a documented allergy and then you are considering the use of a silver sulfadiazine impregnated catheter?
So actually there are two questions. Concern with the first piece was sulfa allergy. The first question, Susan, was related to sulfa allergy.
Are we seeing an increase in sulfa allergies since these catheters have been brought to market?
Okay, no. The answer is no. This catheter and another have been studied and looked upon in millions of cases all over the world. Actually, you know, it's not something which is used in the U.S. And it has never been, because this catheter has been out for 20, 30 years, 30 plus years, and there's never been increased instance of sulfa allergies because of the sulfa in this catheter. And the second piece was, Susan?
The second piece is, how concerned should a clinician be with a documented sulfa allergy when considering the use of an impregnated catheter?
So we have, and not only we, but all over the world, people have used this catheter with the patient with documented sulfa allergy. The material, actually, if you look at the material itself, it is embedded in the catheter wall itself. What that does, it really prevents the issue of biofilm formation. That means whenever you introduce a foreign body in the body, the biofilm starts to form. That's a natural response of the film or the coating on the catheter outside. What happens is when the bacteria get transmitted from the skin or the wall or from outside, they start to land and nest in this area of the outside the catheter. The chlorhexidine and the sulfur and everything kill those bacteria. So the sulfur is not being released in the bloodstream to any degree enough that will cause any allergy. I'm never aware of any study or any case report related to that. Now, there have been 1 or 2 case reports that I'm aware of about chlorhexidine allergy and patient having a negative reaction to chlorhexidine allergy, but I'm not aware of any specific patients who had documented sulfur allergy and this catheter were placed in and they had a negative outcome.
Okay, thank you. Next question, we have a audience member that is asking if a catheter dressing should become loose at the edges, should it be reinforced versus changed, and if you just reinforce it, would the infection risk be increased?
You know, it's really what when people make a statement, beauty is in the eye of the beholder. I will take the same analogy. The loose dressing is really in the eye of the beholder. One thing is, you have a small edge which is, come up, which can happen, versus it is really loose. That means it is you can move it, or looks damp or something like that. In that scenario, the caution would be that if it is slight edge, I don't believe that that makes any difference, because you have to remember, changing the dressing can also introduce infection. That's why, you know, CDC guidelines is you don't change them on a daily basis. There are certain time interval you change, because everybody recognizes whenever you change also, you can potentially contaminate. However, the flip side is that if the dressing appears to be loose or it is coming apart, you don't want to wait, because remember, these acute care hemodialysis catheter are big size catheter. They're connected to big tubing, and there's a lot of traction on them, unlike other routine triple lumen center lines. So these catheter are much more vulnerable for dressing become loose, or if it is slightly loose, become really loose and come off. So in these catheter, the word of caution would be you may want to change the dressing.
Okay, thank you. You also mentioned in your talk today that in 2014 the methodology for central lines will be changing as it relates to dialysis patients and the National Health Safety Network. You did not mention what that change was going to be.
Okay.
Could you elaborate on that point?
I'm gonna read it off you. Actually, I have a printout of CBC. Okay. So first of all was they say, I'm going to read it off. In 2000, this is CDC speaking, not me, Dr. Masud speaking. I'm reading off the NHS. In 2014, an additional field will be added to the CLABSI reporting form. This optional field will allow users reporting a CLABSI to indicate that the patient had a central line in place for the purpose of dialysis. This information may then be used for internal CLABSI quality improvement activity. So this is right off from CDC.
All right, thank you. You also mentioned in your presentation, we've talked a lot about the sulfur sulfadiazine chlorhexidine catheters, but you also commented on the minocycline rifampin impregnated catheters as well. In your experience, have you found either to be more effective at reducing bloodstream infections?
The data supports both the catheters, you know, because that's why CDC has a recommendation and included both the catheters. There's a role for both the catheters. Yeah, so I think I'm not going to go that one catheter is bad and the other catheter is good. I think both the catheters have a role. Now, mind you, to be aware there have been some concerns about, you know, antifungal control. If you have fungal, you know, chlorhexidine, psilocybin has a much more stronger role in that wise, but both the catheters have a potential role of minimizing that. The question is how many catheters, especially in the acute care hemodialysis catheter, are coated with the psilocybin and chlorhexidine, how many catheters there are. And to my knowledge, and I may be wrong, but to my knowledge, the acute care dialysis catheter, the coated one, are the one which chlorhexidine psilocybin. So I think that is what benefits the patient.
Okay, thank you. Why not make biopatch dressings mandatory for all hemodialysis patients with catheters, including outpatient facilities? They're not really used that often currently in the outpatient facility. Can you comment to that?
So the recommendation really you should think of is, you know, their BioPatch is one of the companies which makes BioPatch, but there are other companies also which have dressing, which have chlorhexidine gel impregnated in them also. So I think, you know, our recommendation, they all should get it, because it does make a difference, and it is a slow release chlorhexidine. It does prevent a lot of the contamination issue. The way to making mandatory wise, again, when CDC and other organizations take about, they do on the basis of scientific evidence. They make a 1A evidence, 1A recommendation, that means that has the strongest evidence, 1B, 2B, and everything. So they categorize. So when you categorize certain things, you have to look at how much studies, how much clinical trials have been done. So I think CDC is getting there, because they do mention you should use those things. Making it mandatory at your institution, I think that is something which you should be able to push through, because it does pay off. They are not expensive, and they've got dressing which have fluoride in them, or they can have BioPatch or other products, whatever product that is, it does make a difference. So that is where your role as a champion will pay off.
Okay, thank you, Dr. Masud. This concludes our program for today. I'd like to thank all of you for joining us, and we hope you found this to be informative and will help you to impact the reduction of infections in your institutions. Please note that this webinar will be available for on-demand viewing at www.vesselhealth.org. For anyone who was unable to join us or anyone else in your institution that you think might be interested in this information. Thank you very much.